As a cross-sector collaborative with big aspirations, it is important to commit to these tenets of community inclusivity. And I'll just highlight a couple here. The first is to be aware that we all have a bias that may impact action, and biases are learned and can be unlearned. And another one is to be present, brave, and curious, and to make use of opportunities to connect person to person. All right, next slide, please.
So I want to just take a quick moment to go over the agenda and objectives for today. We've just done our welcome and framing of the day. We are going to be having a local organization spotlight from Open Door Community Health Centers. We always love the opportunity to highlight the awesome work that everyone is doing. So if you're interested in being a spotlight at a future meeting, please let us know, because we would love to have you share the work that you're doing. We are very excited to be joined by DHCS today, who will be giving a presentation in a little bit, and then also participating in a discussion with the group. As usual, we will get our update from our wonderful partners at Partnership Health Plan of California. And then we're going to just wrap up with a few housekeeping items at the end. And I think, as always with these meetings, one of the main objectives really is to build relationships amongst those that are doing this hard work in our region, to learn about what Partnership Health Plan is doing in terms of improvements and resources to help with successful implementation of ECM and community supports. And then today, we're really hoping to increase understanding of the Population Health Management Initiative at DHCS, and to clarify opportunities for cross-sector data sharing for improved care collaboration. Next slide, please. So now I think Jessica is going to introduce our awesome spotlight for the day.
Yes. So each month we aim to spotlight an organization in the region that has approached CalAIM with curiosity and innovation. The spotlight enables a platform for the organization to share their approaches to pain points and solutions to their ECM and community supports implementation journey. It also provides a space for networking and inspiration. This month, we are pleased to give the spotlight to Open Door, a familiar figure in the region. Their mission is to promote social justice and human dignity through exceptional, patient-centered care that improves the health and well-being of patients, community, and staff. Okay, Open Door, the floor is yours. And maybe first I should see whether or not you've been made a co-host. Who will be speaking today? Karina, one sec. Hand it over to you.
Hi, everyone. Let me see if I can share my screen. So my name is Karina Vasquez. I work for First Life Humboldt here in Northern California in partnership with Open Door. Just make some adjustments. Okay. You guys can all see the screen and everything, right? Yeah. Awesome. So to introduce myself, I've been doing this work along with Open Door now for a year. We got a grant, which is the practice grant, where we focus on ACEs work. So we are going to give you guys just a little bit of a presentation of what we've been doing with that work. I'm going to talk to you about the community health worker aspect, our workflow currently, and our plans for the future. And then Sarah will take it on and kind of talk about the cited grant that they got and kind of where the work is going. If you want to introduce yourself now, Sarah.
Sure. Thanks, Karina. Hi, I'm Sarah Ross. I'm the Vice President of Operations South Division with Open Door, and I've been working with Karina and the Practice Grant team to implement our ACEs work at Open Door.
Beautiful. If you guys have any questions while I present, if you want to put them in the chat or hold up to the end, we can do that way too. So let's get started. One of the main two goals of the grant I listed here. The first goal was to strengthen partnership amongst Open Door and First Five medical managed care plans to screen for ACEs and to respond to and help prevent toxic stress. Goal 2 aimed to develop sustainable community-informed evidence-based services to treat and prevent toxic stress physiology and ACEs-associated health conditions among Medi-Cal beneficiaries. So basically, we really wanted to strengthen our relationship with Open Door, First Five and Open Door. What does it look like to have more providers screening for ACEs, trained on ACEs and informed? And then after families are screened, what does it look like? What is the response? And so that's kind of what the CHW, my role has been. So our workflow right now looks like starting with provider screening. So providers over at Open Door have received training on ACEs and screen patients for ACEs. The family has consent and knows what's going on. After an appropriate referral, or after a diagnosis is made and a screening is made, then they get sent over to me. So right now, this is our workflow. At Open Door, a provider screens for ACEs. Once the ACEs is done, then the referral gets sent over to me. And then I work with the families to connect them over to community resources. My goal and our goal with this work has really been to focus on toxic stress. So what does it look like to connect families to stress busters? What does it look like to connect families to community resources that look outside of behavioral health? Would it like exploring nature, information on nutrition, good sleep, supportive relationships, and those type of things. So here I highlighted some of that work. So we address those needs, and we're also working with our community exchange platform, the CIE, to really kind of have a full, well-rounded place to communicate with other organizations. Like this is kind of still in the beginning phases, not only in Humboldt, but with our organization as well. And then these are some of the current services that we do. So like I mentioned, once families are screened, then they get sent over to me. And at First Five, we offer a couple of different services, whether it's parenting support classes like Triple P. We also just started doing Abriendo Puertas, which is focused on Latino families. We just did a 10-week series that ended last week that was really well received. We could do developmental screenings. And it's really nice to have the partnership with Open Door because we can work with providers and get their feedback and family feedback. So we're hearing more classes are needed, then we can implement those at First Five, which is some of the things that we've been doing. We're also working on an ACEs toolkit to have providers all of the information ready to go. So for those of you that don't live up in Humboldt, we are a very rural community. We have one of the largest counties distance-wise. So that means that we don't often have a lot of resources, but we are very community focused. So it's nice to do stress buster focus resources for families that really make them feel a part of the community. With our partnership, we've been working on creating a family resource room over at Open Doors. So taking our work and actually having me co-locate at the space. And what this looks like is this space has parenting tools that look like not only books just for the parents, but books for emotional regulation for kids that we're able to give them, other resources, some helpful mindful activities. And then, so that's kind of what we've been working on for the whole year, kind of really getting that CHW workflow really tied in and really kind of down to a way that works really well for us. We're right now working on what does it look like to have warm handoffs with providers. So if I'm on site and a provider can then send them to me and I can go meet them and really make that transition really smooth. Those are kind of our next steps for the work that we're doing with the CHW. We're also working on harvest boxes with Open Door. They have a community garden there. So we're going to be making them stress buster themed. So families not only are going to get the nutritional value of the box, but then they'll get activities that are going to be correlating with each stress buster and a lot of really helpful information like what does sleep hygiene look like? What does good nutrition look like? If I do want to go outside and I want to do like a family hike, can you guys support that? And maybe putting things on like that. And then I also included the CHW reimbursement. Previously, we had talked about what would it look like if I did the CHW training, maybe at one of the local, or not local, but at one of the colleges that offers it. But through my work experience and things that are coming kind of rolling out, it's not really necessary. So we could do like a letter of attestation right now, which is really helpful. And I think it really speaks for allowing more CHWs to kind of be doing this work where we already have the lived experience and the work experience and the employers to back that up. So that is kind of a brief overview. Hopefully I didn't talk too fast and I hit all the points of what we've been doing so far with the practice grant and where we're kind of going. And then Sarah's gonna kind of talk to us a little bit about looking ahead, ACES work, Cited, and CalAIM.
Great, thanks, Karina. Yeah, we're so delighted by the partnerships that we've been able to build much more closely with both First 5 Humboldt as well as First 5 Del Norte through the opportunity provided through this grant. And so, when we started this program, our clinician leads for the ACES work met with their fellow clinicians and really tried to understand what are your barriers currently to getting trained and certified to be able to do the screening and bill for it, as well as to actually then start screening patients. And the two major barriers for providers was time. It takes 2 hours to do the training, 2 hours that busy clinicians don't have, and then feeling that they knew what to do and what to say to patients once they did screen them and identify that they did in fact have adverse childhood experiences that they were navigating. And so this grant allowed us to create the time. So we were able to block 2 hours of clinic time and pay the clinicians for the time to get the training. And then having partnerships like we've been able to build with First 5 Humboldt has really allowed us to have that support for families once the patient is screened. So we're excited to continue building this partnership and really leveraging the great community resources that exist versus us having to build it all ourselves internally. And we're learning from this sort of project, and we've now partnered with a different organization called VIU, where we have their community health workers, similar to Karina, embedded on site with Open Door, supporting our patients with diabetes. So different priority population, but similar model of sort of leveraging expertise from a specific focused organization, but really embedding them in with our clinical care teams. So we're excited about this opportunity. Additionally, to just for the financial aspect of Karina, once she gets, does the attestation, being able to bill for those services, which will then sustain the program while being very deeply integrated with Open Door. So we are excited to continue our ACES work specifically, and Open Door was just granted one of the Cited awardees. So that gives us more opportunity to really explore how we're going to succeed in implementation of the elements of CalAIM and specifically ECM. And then when we look at CalAIM right now, we've been working with Partnership very closely, Partnership Health Plan, over the last many months, and we're completing our launch process. So we have already started billing for services to Partnership Health Plan, and we're really in that final phase of liftoff of getting all of our components completed so that we can start bringing patients in and enrolling. And we're really open to all of the priority populations because we see just about all of the priority populations at Open Door, given that we are the largest primary care provider in our 2-county region. So I don't know if there's time. I know we only had about 10 minutes. I don't know if there's time for Q&A, but I think Karina and I would both be happy to answer questions.
Yeah, I think we can take a minute or two. Thank you so much for that great summary of the amazing work you guys are doing. It's really, really awesome. Does anybody have any questions for our Open Door team?
And if no questions, that's okay too. I think it was important for me and Sarah to just highlight the beginning of what it looks like to do a partnership like this, to think about CHW reimbursement. I mean, I think all of us in this world are constantly getting updates of this is changing. Actually, hold on, this is how it's gonna look. So kind of living in that world together as an organization has been kind of nice. And so yeah, we hope you enjoyed our presentation. And if there is anything that comes up around this world and anything that we can answer, we have the chat.
Great, thank you. Well, I think I'm going to now hand it over to my colleague and fearless leader, Sue Grinnell, who is going to introduce our speakers from DHCS. Hi, Sue.
Great. Hi, can you hear me?
Yes.
Okay. Welcome, everybody. So I'm hoping Randy and Addie are on. I'm not sure that I can see everyone, but I'd like to introduce our two speakers today that are from the Department of Healthcare Services. I'm going to start with Randy. Randy Arias-Fontenot is a doctoral candidate, and she is descendant of the Sandia Pueblo of New Mexico. She's a resident of El Dorado County for 20 years and well experienced in living and practicing nursing in rural areas for over 10 years. She has practiced nursing in El Dorado, Sacramento, Alpine, Amador, and Yolo counties. Well, you got it covered, Randy. And as a home health, hospice, case management, and inpatient case management nurse. And she continues to provide direct patient care to home health patients in the Sacramento region, in addition to her work for the state of California. Randy has been part of the Department of Healthcare Services and Quality Population Healthcare Management Team, QPHM, as a Nurse Consultant 3 specialist since 2022. Current work streams include enhanced care management for those transitioning from incarceration, members with the highest needs, and members living in rural communities, and ECM for Native American members. She also provides consultation related to providing access and transforming health initiative PATH, that's us, and CalAIM Incentive Payment Program, IPP. Welcome, Randy. And then is Addie with us?
She certainly is.
I am. Hi.
She is. Great. Hi. I just wanted to make sure. So welcome, Addie. So Addie Sherman has over a decade of experience working within clinical experimental psychology, specializing in developmental neuroscience, clinical outcomes, and statistical analysis. Within the Department of Healthcare Services, she is the Chief of Population Health Management, Policy at Quality and Population Health Management. Current work streams include enhanced care management policy, the population needs assessment, community health assessments, and community health improvement plans, PHM monitoring, managed care plan, contract compliance, and the PHM service, transitional care policy, TRIO benefit reporting, managed care encounter and claims data reporting, and the CalAIM incentive payment program. And I'm not sure how either of you are able to sleep. Sounds like you're doing a lot. So I think with that, I'd like to, do we have some slides?
I did send those over.
Great.
Voila. There we are. So let's get started. I don't want to take up too much of your time. As Sue is very generous in with her introduction,
Randy, it seems like you went on mute.
Am I off mute? Can you hear me?
Yes,
Yep,
I can
now
hear
we
you.
can.
Thank you.
Okay, perfect. Actually, a lot of people prefer me on mute, so it tends to work better that way. But for today, I'll be off mute. Thank you very much for that introduction. I'm Randy Arias-Fontenot. I'm one of the nurse consultants here with Department of Healthcare Services. And I am joined by Addie Sherman. And we're going to talk a little bit about this wonderful collaboration that we have with y'all. And I do want to start off by saying thank you for the work that you do, because y'all are on the front lines. You're seeing exactly what folks need and how they need it. And that means a tremendous amount to me, because from my aspect, I have an idea, but I don't know exactly what's going on. And I rely on your voices to share that with us so that we can get this right. And I'm really excited to work with y'all today. Next slide, please. So let's talk a little bit about transforming Medi-Cal. I want to rule the world and open it all up. So let's transform Medi-Cal. Next slide, please. First and foremost, brief overview. As you all know, Medi-Cal offers low cost or free healthcare insurance to Californians with lower incomes and with various disabilities. Some of the coverage is medically driven, such as doctor's visits, prescriptions, dental and vision, is in addition to mental health services, substance use disorders, and in the concept of transforming, we are looking at even more. So Medi-Cal is unique. There is Medicaid in other states. We have Medi-Cal. It is particularly unique for our state. And with what we are hoping to change and innovate, we will look forward to providing even more. Next slide, please. Medi-Cal by the numbers. Medi-Cal coverage is provided to approximately 1 in 3 Californians and more than half of school-age children in the state. 65% of Medi-Cal members are people of color, with 5% of our members having the highest cost needs. And considering that 20%, and that was at the time that this particular slide deck was put together, and dare I say it's probably a bit more, 20% of Californians were considered food insecure. With our current state, I would say that that is probably a bit more. And Californians spend approximately $7.2 billion annually on healthcare associated with food insecurity. And then more than 2/3 of our long-term care patients are also Medi-Cal recipients as well. Next slide, please. As I said, our goal is to transform Medi-Cal so that we can increase services and provide equitable care to all Californians. We're looking at having access to new and improved benefits, really looking at our members holistically, not just siloing them in relationship to a disease process, but really looking at them in all of their needs. And that may include things such as housing support, to provide that safe and stable housing, especially when recovering from illness. Medically tailored meals to support recovering from illness, and integrated and coordinated care for those with long-term needs. I believe in our prior presentation, they spoke about that warm handoff, really a key component for many of our more vulnerable members. Next slide, please. So what are some of our goals? Again, looking at that whole person care approach to looking at some of the social drivers and acknowledging and addressing the social drivers of health. Our health isn't just what is in our body. It is, as you all know, impacted by many of the things that we experience in our life outside of our body and how that relates, including improved quality outcomes, reducing the health disparities through that delivery system transformation, and providing consistent, efficient, and seamless Medi-Cal system across all avenues. Next slide, please. So what Medi-Cal is, it's building a more equitable health system. And it's going beyond the doctors and the hospitals. It's really meeting our members where they are. So yes, we're not gonna overlook physical health care. We're not gonna overlook mental health, or substance abuse disorders and dental care and vision service. Those will still be covered. However, what we are looking at is to, in many respects, demedicalize additional services that we can provide to patients. So really expanding, and with the goal of providing more of a comprehensive, personalized, and well-coordinated care. And that is through the population health management, enhanced care management, community supports, and justice-involved initiatives. And also looking at standardizing benefits across the state so that Californians, whether they're in the north or in the south or anywhere in between, have access to the same high quality servicing and care. So whether they're in an urban area, in a rural area where I am all too aware of many of the challenges of access, really trying to level that playing field, if you will. Looking at behavioral health modernization, managed care plan transformation, Medicare and Medi-Cal plans, and then coverage for long-term services and support. Next slide, please. So what are some of the Medi-Cal transformation initiatives out there? Next slide, please. One of them is population health management. Next slide, please. That is a team that I am on, and that Addie is also a part of. And this is the purpose of our population health management is to establish a cohesive and statewide approach. That is the Medi-Cal transformation. And what we're looking at is accountable plan of action is that really building trust and meaningfully engage with our members. Gather and share timely, accurate data. We are still working on a service that we hope to be able to provide statewide so that we have an ability to have really good data sharing across the board for members and for those providing care. Being able to connect the members to preventative care and other care management and transitional care services, as well as really reducing those health disparities by linking our members to public health and social services that address their health-related social needs in conjunction to their physical health. Next slide, please. So some of this little diagram here gives us an idea of some of that person-centered approach, looking specifically at children and families, the adults, folks with disabilities, and then older Californians through risk stratification and identifying needs, prevention and wellness, and funneling that into whether that individual would be best served through enhanced care management or community supports might work for them as well. Both of these services being provided by managed care plans at varying levels. We're also taking into consideration foster youth, those with medically complex needs, people who are justice involved, people with serious mental illness or substance use disorders, and those experiencing that are unhoused or experiencing housing instability, and then folks that are at risk for institutionalization. We're really looking at the individual in a very holistic manner to find the services that are best suited for them, that they need and that they want. Next slide, please. So what are ECM and community supports? Next slide, please. So enhanced care management and community supports, two totally separate initiatives, two different departments. I myself work specifically in enhanced care management. However, there is some overlap and a significant amount of communication between the two different teams. So enhanced care management is designed for the folks with the highest level of needs. It is a very active process, high touch, high communication, really where that warm handoff works extremely well. These are our members that have the greatest need. And they can either be referred into enhanced care management by their primary care physician, managed care plan, or as well as they may self-refer. The community supports are 14 new services that are designed to address members' health-related and social needs. Managed care plans are encouraged but are not required to provide these services to help members live their healthier and better lives. Enhanced care management is a required benefit. So that is probably our biggest separation between the two areas. Next slide, please. So we're really early in our journey relatively speaking. And I think, I really want to paraphrase our leader, Paula Barberera, forgive me, I'm really bad, is that this is in ECM is and community supports is a journey, it's not a destination. And that is probably, at least for me as a nurse, one of the hardest things to wrap my head around, in that, oftentimes we're working with an individual and we're gathering things and we're getting them together and we're providing services, and there becomes essentially an end point. When it comes to ECM, there really isn't a particular endpoint. Right now, it is a process, it's a journey. And so what you will find is that various programs have rolled out and will be continuing to roll out. We are not expecting to implement a program that's going to be perfect right off at the get-go. And that, boom, it's a one size fits all. That is not the case. Rather, this is it's an adventure. It's a big adventure. And we will constantly be refining and changing, hopefully not too quickly, for everyone involved, to really meet the member where they are and their needs. So it, yes, it is, Sue. Yes, it is an adventure. It is a journey. And so what ECM and community supports are designed to address are the several complex health conditions. For our members, both in Medi-Cal and Medicare, or also known as with dual coverage, are more likely to report being in poor health than Californians that are only on Medicare. And also here to address higher rates are populations that are experiencing higher rates of diabetes, hypertension, HIV, and mortality. And really working with those with complex needs that are experiencing a variety of healthcare delivery systems. As anyone who has been in the healthcare industry knows, it's not an easy thing to work through, to coordinate, whether you're a advocate for a patient or family member, or you're someone receiving healthcare themselves. It's not a simple process. And so it is one of our goals is to help to simplify it and make it easy for folks to get the services they need. And again, more than 65% of our Medi-Cal members are from communities of color, some of our most vulnerable patients. Next slide, please. So what is enhanced care management? Again, this is enhanced care management is for our members who have the highest need, most complex cases. And so our vision is to coordinate care for all eligible members, physical, behavioral, dental health, across the board. So ECM, high touch, person-centered, and provide primarily in-person interaction. That's our goal. And doing so where the member actually lives, where they are seeking care. So for all of you out in the community, you're doing the work. You're the folks that are, hats off to you, because you're providing that person-centered, high-touch, one-on-one care that is so important to these individuals. Transitional care for all MCP members, they may transition between ECM, complex care management, and then basic population health management. So they may transition up or down through any of these categories, depending on their healthcare needs at any point in their life. Next slide, please. So what are some of our core services? So ECM is available to all members until their care plan needs are met or they choose to opt out of the benefit, which they may do at any time. And again, the individual may either self-refer, refer by primary care physician, or folks working within a community-based organization. So What are the core services are outreach and engagement, the comprehensive assessment and care management plan, member and family supports, enhanced coordination of care. And enhanced coordination of care includes scheduling appointments, coordinating transportation, accompanying members to appointments as needed. Coordination and referral to community and social support services. ECM lead care managers are encouraged to screen ECM members for community supports as well, and refer to those supports when eligible or available. So they're not, those services are available to that individual, as well as health promotion and comprehensive transitional care. Next slide, please. So who is eligible for ECM? Any individual and family experiencing homelessness, individuals at risk for avoidable hospital or ED utilization, individuals with serious mental illness or substance use disorders. The go live dates for those were back in January and July 2022. So ECM for those folks rolled out at that time. In January 2023, those adults living in community and for at risk for long-term care institutionalization, as well as adults in nursing facilities transitioning to the community went live. And then in July, most recently in July 2023, children and youth population of focus went live. And then individuals transitioning from incarceration, as well as birth equity population of focus. And actually there is a slight challenge right here. So birth equity population of focus is scheduled to go live in January 2024. Individuals transitioning from incarceration, I believe is at a slight delay at this time. So January 2024 may not be the correct date. But birth equity population of focus is definitely going live in January 2024. Next slide, please. Community supports, our sister partner. MCPs are not required to offer community supports. They are highly encouraged to do so. And some of the things that are provided under community supports include community transition services, medically supportive food and meals, home modifications, sobering centers and day habilitation, as well as housing supports for members. Members do not need to be eligible for ECM in order to receive community supports. The managed care plans must partner with local community-based organizations to provide culturally appropriate services in communities, and you have to attest to that as well. Optional for MCPs, again, this is optional, and that each managed care plan may provide any variety of combination of community supports to their members. So you do want to make sure that you're working closely with that managed care plan to see which ones they offer and which ones they don't. Next slide, please. And so below the services that are approved by community supports in lieu of services and include the 1115 waiver services. So housing transition navigation services, deposits, housing tenancy, caregiver respite services, really important, nursing facility transition and diversion assisted living facilities, personal care and homemaker services, medically supportive food meals and tailored meals, asthma remediation and sobering centers. The 1115 covers the short-term post-hospitalization housing and recuperative care, also known as medical respite. Next slide, please. So let's cover a little bit about long-term care services. Next slide, thanks. So statewide access to manage long-term care. Starting in 2023, we have included skilled nursing facilities by 2024. Coverage will include intermediate care facilities for persons with developmental disabilities and subacute facilities, including pediatric facilities. So managed care plans are required to cover and coordinate these services. In addition to comprehensive services, and really actively working to ensure that seamless care transition and provide care for in the most appropriate setting for that individual. Really looking to have the least restrictive setting for the individual that is still safe. And then ensure access to ECM community supports for the long-term care resident, and then additional support services, and definitely including medication oversight and 24-hour on-site direct care staff as well. Next slide, please. So let's talk about my favorite areas, which is funding capacity building programs such as PATH, IPP, HHIP. Next slide, please. So how do we build some of these Medi-Cal partner capacity? How do we build these relationships? So we have three really particular ways. My personal favorite is PATH. I do sit on some of the different review processes for PATH. So as many of you know, it's a 5-year, $1.85 billion initiative to fund. And I want to make sure that y'all get that money. So please apply. Please, please, please apply. It's a collaborative planning and implementation. It's for capacity and infrastructure transition, expansion, development, technical assistance, marketplace, including guidance, in which community-based organizations can become part of the technical assistance marketplace and be compensated for providing technical assistance to other community-based organizations so that they can share their knowledge and build that robust network. Another is the incentive payment program. This is a $1.5 billion initiative that provides financial incentives to managed care plans to invest in ECM and community supports providers and their health exchange and data exchange infrastructure. In addition to capacity building and community supports, ECM and community supports capacity building, and promoting the performance and improvement of Medi-Cal programs. So this is funds that actually go to the managed care plan to bolster services. And then third is the Housing and Homeless Incentive Program. This is a 2-year, $1.29 billion initiative that provides financial incentives to managed care plans to, again, continue to build that infrastructure and build those partnerships and actively reduce homelessness for individuals that are their members. Next slide, please. So a little bit more about PATH. There are various points of which you can apply for various rounds for which you can apply for funding. And rounds 1 and 2 have already gone, and funding announcements will be sent out. And then round 3, forgive me, I do not know the exact date of which applications were required to be submitted by. We still may be actively accepting applications for that, but do not quote me. I will find out for you. And so each round has a little bit more of a focus. So the initial round was identifying and addressing housing related issues. The second round was looking at housing related community supports providers and infrastructure development. And then looking at, third is medically tailored meal providers, so on and so forth. So we want you to apply. The money is there. I kid you not, I review these applications. I really, really want you to apply. I cannot plead enough for that. And then also technical assistance. This is the Marketplace Initiative under PATH, where as a community-based organization, if you'd like to be a part of the technical assistance marketplace and share your wealth of knowledge. Again, there is a potential for compensation for that. And we encourage all county agencies, public hospitals, tribal partners to be a part of our technical assistance marketplace. Next slide, please. The IPP, the Incentive Payment Program, this is a voluntary program, but the goal is to continue to support the expansion of ECM and community supports, and to invest in the following priority activities. So delivery system infrastructure, supporting that core ECM and community supports providers, health information exchanges, also ECM provider capacity building. So these funds are to be used for that capacity building, supporting ECM workforce training, TA, workflow development. And then when coming to community supports provider capacity building and MCP take up. So supporting community supports workforce training, TA, workflow development. And our participating managed care plans are required to report on a minimum number of optional measures. So just something just to keep in mind. And they're payment based on the successful completion of performance against these measures. Next slide, please. For HHIP, it is intended to reward the managed care plans for developing the necessary infrastructure to connect their members to needed housing services. It's used to incentivize the managed care plans to take an active role in reducing and preventing homelessness, as we mentioned earlier. And to participate, the managed care plans must partner with their homeless continuum of care and others and submit a actual local homelessness plan and an investment plan that was required in 2022 and from 2020 to 24. And next slide, please. We are just about done. Managed care transitions. Next slide, please. So multiple channels starting in 2024, new mix of the high quality managed care plan available to members. There is going to be a new mix. There's contracts with commercial managed care plans were announced in December 2022 and have been underway since 2023. Conditional approval has been provided for 17 counties with their managed care model, including some single plan model and expansion. There is a direct contract with Kaiser in 32 counties in which Kaiser operates. And again, that does any of these mixes of managed care plans still are required to meet the same guidelines that have been established for ECM and community supports from the very beginning. With the goal of improving the health equity, quality, accountability, and transparency. Next slide, please. So new requirements of these partners include again, transparency, quality, continuum of care, local presence, engagement, must address the social drivers of health, accountability and commitment to compliance, and really focusing on value-based payment and emergency preparedness and essential services. And most importantly, to me, culturally appropriate care that cannot be overlooked. Next slide, please. Again, these below are just our basic requirements and some of the provisions. Next slide. More of those. Next slide. And you will be able to have access to this deck. And goal is that members are going to have that easy access to information. This is comprehensive, person-centered, and social services. Members, they're going to have that access. They will, taking into account cultural, sexual orientation, gender identity, and preferred language. And the physical health care integrated into behavioral health. We cannot separate those. We must look at these individuals as a whole person care. Next slide, please. More on the transitions. Currently involved in transitioning, planning, stakeholder engagement, provider outreach, so forth. Next slide. Dual eligible members. Go ahead, next slide, please. Integrated care for the dual eligible members are Medi-Cal, or Medi-Medi, our patients with Medi-Medi. 2 initiatives went live here. Next slide, please. Behavioral health, next slide. This is just a brief timeline of some of our areas that have gone live. Again, this is a journey, not a destination. Next slide. Again, some additional workflow there. Next slide. This is just an overview of how this may look, how our behavioral health services will roll out. And next slide. And then contingency management programs that will be out there. Next slide. And finally, Justice Involved. Next slide. Justice Involved is a very new program. We will be the first in the nation to roll this out. It will provide services to those that are leaving incarceration and coming back in, and providing seamless services between those in between the medical services and social services, inpatient, and then on their way out, and providing a warm handoff. Next slide, please. Key, as these individuals are considered some of the most vulnerable individuals related to mortality and health outcomes. Next slide. And that is it. What questions do you have for us?
Okay, I cannot for some reason get my video to come back on. Randy, that's a lot. It's how do you have all of that in your head? We have a number of questions that came to us that we wanted to answer, but I think we've gone a little bit over. So I think we're just going to answer like 1 or 2 of the ones we had ahead of time, and then open it up to the group. And let's see, Jessica, would you? Thank you. Or Katie. So first question that we have is, what is the DHCS vision for how MCPs can best support successful implementation of care coordination, navigation, and referrals across all health and social service providers, including community supports providers? That's a big one.
That's a big one. That's a really big one. Addie, do you want to?
Yeah.
Yes.
Okay, I'm just
Yes.
going to take a drink of water really quick.
Yeah, and thank you, Randy. Yes, that is a lot of information to cover. It's part of why, as Randy said, this is a journey and not a destination as we continue to roll out such comprehensive care models and updates to the Medi-Cal system. So our vision for supporting successful implementation of care coordination in particular, I think it falls into a couple different categories. For one, we're really hoping to develop stronger partnerships with managed care plans, and really hope to assist in making sure that we more closely follow members and make sure that care, whether it's mental health, oral health, vision, across various different settings, is coordinated. And while ultimately, the compliance will fall to managed care plans, we certainly hope to be a very strong partner in establishing some of these new relationships and procedures with local health entities across various different social services, and hope to really support you all in rolling out this policy and really making sure that we track members' needs across various different environments. And then I will say, I think this was mentioned in another question. I'm not sure if this is jumping the gun, but we also will say a major goal is for 2025 when closed loop referral policy will be rolled out. So 2024 is really going to be a year of, starting to reach out to local health entities and all of these different health organizations to really start building these relationships that will hopefully then allow us to get to that place where we have fully closed loop referrals for members seeking services across, the multitude of different organizations by the time 2025 rolls around.
Just around the corner.
Yeah,
Right. Thank
I know
you.
it's coming up closer than
It is.
what I would have thought.
Zachary, Zachary, I think I saw your hand raised.
Yeah, I just had a quick question on the definition of birth equity population of focus. Can you expand on that a little bit?
Sure. Randy, do you want to take that one since it's enhanced care management, or we can also, some of these topics we are not leads on, so we're also happy to take questions back and get more.
If you don't mind, I would like to take that back to our birth equity lead. That is definitely not an area that I work very closely in and certainly don't consult on. As far as a nurse is, I'm on the other side of the spectrum. But if that's okay, we would love to take that question back.
Thank you.
I will say our enhanced care management and population health management policy guides on our website are very up to date. We try and update them as much as possible and do have a comprehensive outline of our various populations of focus. So that would be a great place to start. And then you can also feel free to reach out to us personally if you have more specific questions, and we'll be happy to answer those as well.
Great, thank you so much. I'm wondering if we have questions from the group for Randy and Addie. Jessica, hi Jessica.
Hi everyone, Jessica Osborne, Staff Smith. I'm the COO for the North Coast Health Improvement and Information Network. We're a health information exchange and a community information exchange. And so I think I have sort of a particular bent maybe. I guess I'm interested to hear from Addie and Randy, what's your goal in terms of some of the closed loop referral work that you're doing in terms of working with the nascent networks that are in place across California so that we're not creating redundant systems?
Absolutely. Love that. I mean, I would say it's one of my primary goals is to reduce redundancy as much as possible. And I think we are definitely starting to prioritize that more moving forward. One of the ways definitely would be through our population needs assessment process. So reorganizing how we expect managed care plans and local health entities, how we expect them to collaborate moving forward, and opening lines to have more for thorough communication between various different parties at the county level. We also, I know, have been relying a lot upon memorandums of understanding that DHCS is helping to coordinate. So making sure that, we come to the table and also help you partner with various different entities and managed care plans. And then also I would say, just conversations like this really help, hearing any kind of issues or problems that come up. I know we also had some great discussions at the Quality and Health Equity conference we hosted a few weeks ago as well. I don't know if anybody was able to join that, but we had some great speakers and got to hear a lot about people's, inventive ways that we are hearing from folks and how to roll out systems and best utilize resources in order to reduce duplication.
Thank you. And sorry to put a fine point as a follow-up. So it is the vision of DHCS that you're going to use existing networks that exist in California. You know, there's a handful of regional HIOs and other systems in place versus offer a state-sponsored product.
So for the closed loop referrals and specifically, you mean?
Correct.
Or that I am unable to give you a definitive answer on that, but I know in general we hope to utilize, you know, existing pathways and services as much as possible. But the closed loop referral specifically, I would need to confer because I know I haven't been. We have so much rolling out in 2024 that's been kind of on the back burner for now since it's coming out in 2025, but would love to continue to discuss in the future for sure.
Thank you. Appreciate it.
Great, thank you. It looks like we have a question in the chat. Any insight on whether community supports will be a benefit as opposed to in lieu of service in the future?
Yeah, that's a great question. I mean, I would imagine so. Like the goal is always to, you know, collect more data, see what's working, have, you know, as this is such a long process of, you know, such a comprehensive rollout, I imagine there would be avenues in the future, but I can't comment to any, you know, near term updates to that.
Great. Tracy Rattray, I saw you come off no video. Did you have I'm putting you on the spot. Did you have a question?
Here I am on video. Good afternoon, everyone. Thanks, Sue, and thanks, Patty and Randy for your presentations. So my question is the new, I think it's now a mandate for local health departments and managed care plans to collaborate on community health assessments and corresponding community health implementation plans. Is that associated with CalAIM, or is that a separate directive from PHM to MCPs?
It's kind of both. So the new collaboration requirements surrounding both the CHAWS and the CHIPS are part of kind of the reorganization that we have around the population needs assessment. And technically that is population health management. So that is part of CalAIM. But this is also a new directive. Like I mentioned, we are trying to reduce redundancy and duplication of effort as much as possible moving forward. So this is kind of a new directive that we are partnering with the Department of Public Health on to coordinate this amongst local health entities and managed care plans, excuse me. So kind of both, but it is part of CalAIM. It's a directive under population health management.
Got it. And that's sort of a prelude to a follow-up question. I'll ask briefly. So I've been working in this field for a long time, and I know that often the CHA and CHIP process include community input, and that's been done in a number of counties. I'm wondering if there's any opportunity to require local health departments and managed care plans to include a CBO representative on some sort of steering committee that would oversee the CHA-CHIP process.
Yeah, I mean, I definitely say there's an opportunity for that. I know it's been discussed in the past. I don't think we have any plans to formally require it, but I mean, yeah, would love that. I think it's, you know, as much as possible, we can coordinate efforts and have representatives like that. Yeah, that's a great idea.
Thank you.
Mm-hmm. I will say too, with the PNA, we have additional guidance coming out in December surrounding the partnerships between local health jurisdictions and managed care plans. So we'll be happy to share that around mid-December. I think that's going to be coming out. And it should also be updated in the PHM policy guide. So there should be more information there as well.
Great. Thank you so much. And Tracy, you did great. Sorry for putting you on the spot. So I think I'm going to turn it back over to Catherine Stewart.
Thank you, Sue. And if there's any other questions that you all have that we didn't have the opportunity to answer, I encourage you to put them in the chat and we can follow up with Randy and Addie with those questions after this meeting. So I think now, Katie, can you pull the slides back up, please? Now I am going to turn it over to our amazing collaborators from Partnership Health Plan of California, who are going to spend a few minutes providing updates on process improvements and providing other updates as well. So Ashley or Bianca, I don't know which one of you is going to be speaking.
I can take it away.
Thank you.
Of course. Hello, everybody. Okay. You can go ahead and go to the next slide. We just have a few updates for you today. This one up top is probably the biggest update we want to share. Unfortunately, we just found out that we have a pretty big conflict in our expansion counties for the referral source webinar that we were going to be hosting on Thursday. So we will be postponing that webinar. We are working right now internally to find a new date that works for everybody. With the 10 new counties that we are going to be having coming on in January. It's getting a little bit harder to pick a great date for 24 counties, but expect an email today with a new date on that, with a new registration link. I also apologize. I know a lot of people had a hard time with the registration link, so we are also testing that to make sure that's not going to be a barrier at all. But if you do get the link and you do have an issue with registering for the new date, please reach out to us, either the CalAIM inbox or the community supports or ECM inbox, and we will help you find a new link for that. We will be hosting a transportation benefit overview. That's going to be for our ECM and community support providers. We put December or January, but we are working with our transportation department here in order to define a date. I think it's going to be towards the end of December, but you will be receiving another email on that as well, and we'll also share it with our friends at Phil to distribute to this group. Another training, we love our trainings. The ECM team is going to be providing a Excel basics training for our ECM providers. So we sent out a doodle poll and inquired about dates that might work for our providers. We narrowed it down to 2 dates. So we're going to be sending out another one in order to select the one that works for the most of our providers. And it's just going to be going over, the simple Excel basics that you have to do in order to submit your reports. So, like how to prevent those sins from transposing to a scientific format and all of those fun things. And then our December population of focus, we are hoping to spotlight next month in the CPI on the birth equity and justice populations of focus. So more to come on that. Next slide, please. Okay, and here are a ton of resources for you. Again, our ECM and community supports webpage, also our care coordination department. If you are needing help with a member, please reach out to them. They are able to look up ECM related questions. They're also able to reach out to the community supports team and the ECM team. So super helpful there. Transportation, as a reminder, we do our transportation in-house at Partnership. So if you need to schedule a ride for a member, reach out to that 866 number there. We did meet this morning and heard from our transportation department that they hired more staff and that the wait time is being cut more than in half. So we're super excited about that. And then also our provider relations and our claims telephone numbers if you have questions about TARS or your contract or anything provider related, and then also with billing and claims. And I believe that is it from me. Are there any questions?
Ashley, could you put contact information in the chat so that I could get added onto those trainings?
Absolutely.
Thank you.
Any other questions for our friends from partnership?
Hi, good afternoon. Roxanne here with Mom's Mills. Thank you, Ashley, for providing that wonderful update. I just had a quick question since my role is predominantly about engagement and marketing awareness for referrals and how to tap into this wonderful resource. I was wondering can we expect an updated referral form from partnership? As we know, DHGS is standardizing eligibility come next year, and I was just wondering if we have any updates regarding that.
Hi, Roxanne. Are you referring to the ECM referral form or community supports?
Sorry about that. Community supports referrals.
No worries. Bianca, can you take this one then?
Yep. Hi, Roxanne. Thanks for the question. Yeah, we're still trying to figure out internally. Actually, we're just waiting to get approval through our legal team and all that. But once we have the changes set, we will make sure to let everyone know. We'll likely send out an email, and then again in the roundtable, the community supports roundtable, that will happen in January. But thank you for bringing up that question.
Awesome. That community supports roundtable, is that open to everybody, or can I make sure I'm invited to that conversation? That would be great.
Yeah, absolutely. So let me actually grab the link real quick. It's on our website, and you can register for all of the roundtables for next year right here.
Awesome. Thank you, Bianca.
You're welcome.
Any other questions for Bianca or Ashley? All right. Well, if you think of anything, please feel free to add them to the chat. We are now going to just spend a minute or two as we wrap up. We have a event evaluation survey that we're hoping you can spend a couple minutes doing. It really does help us see how we're doing and really informs the programming for the rest of our events. So I think that Jessica's putting it in the chat right now. And you can also scan the QR code that's on the slides. Next slide, please. So as you are filling out the survey, I just wanted to remind you of a few upcoming events. We are having our next CPI regional meeting for December is going to be for the Northwest on December 20th at 1 o'clock, the same timing. So we're hoping that you can be there. And actually, if you have a minute and want to indicate in the chat if you are going to be able to attend, that also helps us with our planning for the meeting. The ECM roundtable with Partnership Health Plan, their monthly roundtable on ECM. If you were unable to attend and would like a copy of the chat or the Q&A, you can let our team know and we'll be sure to get those out to you. And you can see that in the appendix of our slides, which will be available on our website, more details. And I believe there's also a link here to register for the monthly ECM roundtable. And Jessica, maybe for the next meeting, we can include a link for the community supports roundtable as well. That could be helpful. We are also going to be hosting some office hours in December. We have the 2 dates listed here. And this is just really an opportunity for you to come drop in with any questions. You can even just drop in to say hi or to talk through things that you're working on. And we will do our best to find answers. And if we don't know the answers, we will go hunt around and see what we can find for you. So we've had a couple we've had a couple of office hours over the past couple of months, and it's actually been really, really helpful. And often it's just 1 or 2 people that show up, but we've really had the opportunity to kind of learn more about the work and that's going on and things that we can do to better support your implementation of ECM and community supports. Next slide. So this event may not be relevant to many people in this particular region, but I know that some of you work across regions, and come January 2024, Kaiser Permanente will be part of many new counties. So we are hosting a pop-up event with Kaiser Permanente next week on Tuesday, December 5th. And Kaiser's just going to come to talk to us about what the transition is going to look like and be there to answer any questions you might have. So I believe the registration information will be going out today. So hopefully you can make it if you are interested. Next slide, please. Well, I think that's it for our programming for today. I don't know, can you go back to the evaluation slide perhaps in case anyone needs to grab that QR code? So yeah, if you all want to just take a couple minutes and complete the evaluation, again, we would really, really appreciate it. I also want to extend a huge thank you to all of the speakers that joined us today, our Open Door friends, and Randy and Addie, and for all of you for joining us today.